Hello, well, my name is Jenny Chich. I'm a clinical psychologist working on the ADAPT study. And this is my colleague, Geoff Davies, who's also a clinical psychologist in the same study. We're going to talk to you a bit today about what the study is and what our roles are within this and how we've come to experience neurodiversity within this project. So I'll start with talking a little bit about what ADAPT is. So ADAPT is a novel treatment focused on reducing anxiety in people with hypermobility. And we've been working on this project since October of last year, although it has been going for some time before this with Dr. Jessica Eccles as the principal investigator. And we've been involved in completing assessments, looking at whether people are eligible for the study, and then we'll be looking at testing the effectiveness of the interventions. Geoff, would you like to talk a bit more about that?
Yeah, hi, I'm Geoff. So myself and Jenny were primarily employed as clinical psychologists. So we work on the project in as much as we're delivering the interventions themselves. There are two types of intervention to be delivered, one which focuses more on emotions, another intervention which focuses more on brain-body links and body awareness. So whilst we do a lot of the research side of it as well, in terms of arranging the participants and screenings and assessments, we also deliver the interventions. As such, the role of neurodiversity has cropped up in terms of who comes into the study, but also how we deliver the therapies themselves to be best inclusive of those with a neurodiverse background that aren't ineligible for the study, which we'll touch on in a bit more detail later, I guess.
So just to talk a little bit about our backgrounds, prior to this, Geoff and I both trained as clinical psychologists at part of Surrey and Borders Partnership Trust, and we had placements in various different areas, including working with people with mental health difficulties in working age adults, older adults, learning disabilities, children and young people, and also a specialist placement, of which mine was focused on working with people with long-term physical health difficulties alongside having some mental health challenges.
I undertook the exact same training program that Jenny did. We actually trained together, and we go through our core placements as Jenny's described. Personally, I worked in my learning disability placement in a unit aimed at challenging behaviours people were detained under the Mental Health Act, which was sent in a learning disabilities context. However, the unit itself had a autism angle and a specialist interest in people that were presenting. So I guess my main experience working with neurodiversity was through this placement, which was an inpatient unit which had 10 men and 1 female resident in them. I also did a learning disability placement where we obviously work with people with autism or autistic people. However, this was very much embedded within a learning disability context for how I was encountering these people, which is very different to the trial we're working on, which we'll get onto in a bit, I guess. In terms of neurodiversity, I've already kind of stumbled upon this issue. We're aware there's different schools of thought on how we refer to people with autism or autistic people. For the purpose of this talk, we are aware there are different ways of approaching this description. We're not going to make a particular judgment on that during the talk, other than we're going to try and approach it from an overarching neurodiversity perspective. And if we use certain terminology, we are aware there are different schools of thought. We're just doing our best to use the terms we've been trained to use as most comfortable for people. That's not to say there aren't other terms to be used, and we're not dismissing them at all. Okay. Yeah. Should we talk a little bit about screening now?
Yeah, so during when we started doing assessments for the study and looking at whether people were eligible for the anxiety intervention, we were screening for autism using the autism quotient 10, which is quite a short measure. with 10 items, and we just found during the assessments that this wasn't really giving us enough detailed information about neurodiversity or people's experience. So we changed this down a little bit further down the line to use the RADS, so the RITBO Autism Asperger Diagnostic Scale Revised, which is a much more in-depth assessment. So this has been giving us much more information relating to neurodiversity and people's experience of social interactions and ways of living with routine and other aspects of their lives, which has been a much more insightful investigation to start with, to then ask people questions about, rather than just having 10 items prior to this.
I mean, something else is probably important to discuss briefly before we go into the reflections from our actual clinical work on with ADAPT is, during our clinical training, we were obviously taught about autism and ADHD and neurodiversity. However, something I personally think very interesting as a newly qualified clinical psychologist, suddenly going into a trial which wasn't under the auspice of neurodiversity when we got the jobs, was our training felt very much embedded within autism within the context of a learning disability, or certainly autism within children. And there's quite a established perception of how you will encounter autism, both with ADHD, lots of hyperactive children climbing over chairs in therapy rooms, and also people with autism very much with a comorbid learning disability, are often the people that are cropping up in our training program, and certainly in our learning disability placements where we get a lot of our experience. Personally, my speciality placements weren't working with neurodiverse people, so it's been quite interesting encountering this in working age adult context, because what my training would necessarily have taught me to expect when I go into the working world as a clinical psychologist. I'm not sure what Jenny's experiences were from the training program, but
yeah, I think my experiences are quite similar to what Geoff's described, and working in working age adult community mental health services. Autism wasn't something that was discussed very much, or ADHD or neurodiversity at all, and was much more of a focus in CAMS, so child and adolescent mental health services or learning disability services. So it was something that I wasn't necessarily expecting to be as common as we've been finding, or the possibility of neurodiversity being common recently. It came up very briefly in my specialist placement, with someone with various long-term health conditions, and there was a question mark raised by a community mental health team about autism, but it wasn't really something that was necessarily expecting. So yeah, it wasn't something that was covered particularly in our training very much in terms of adults who didn't have a learning disability.
I mean, certainly, I actually work 1 day a week in a children's hospital alongside the trial, because our trial jobs are 4 days a week, which is in a paediatrics functional first service. And a lot of our children, you would expect, have hypermobility, and it's very much viewed as a functional disorder, a lot of their clinical presentations. And actually, looking through the lens of the trial now, suddenly I'm noticing there's quite a lot of young people coming through with potential neurodiverse presentations, which maybe aren't labelled as such by clinicians initially, and certainly not when people are in their teenage years. So we're kind of, we've both got background in some slightly more physical health context as trainees and as clinical psychologists, but it's not as acknowledged as maybe our experience in the trial are beginning to elicit. And I can certainly say I'm now kind of spotting things in my other job which kind of link up quite nicely with ADAPT, which I wouldn't have expected. So when I spent 6 months as a trainee, I didn't spot these kind of things, whereas now, because of the trial, I'm working as a qualified psychologist, and it's highlighting my own lack of maybe knowledge of what to expect and how the lens to view our formulations from, and my other job as well, actually.
Geoff, what would you say one of the key kind of themes or things that you've been reflecting on has come up?
Well, kind of, I guess one of the reasons why we're speaking today is with hypermobility, we know a very, very high proportion of those people are women. And therefore, when we were initially looking for neurodiversity for screening for the study, we were approaching it from a quite traditional background of what we'd expect people that are neurodiverse to look like. However, a lot of my own experiences haven't been that, we've been looking up these ideas around what to detect, and actually you can run through, I don't know if this would be helpful, but we use something called the mini diagnostics interview, where, because we're trying to explicitly look at the type of anxiety, but also other clinical features like OCD, PTSD, etc. And then we do a more elaborate psychological interview specifically looking at anxiety and general mental health. And it's amazing. Quite often, when you're only asking the same questions, you get the same responses. It's only when you go off track a little bit, and people can just say, no, they're not experiencing these things. Do you like routines, for instance? And people are like, well, no, not particularly. And then you don't explore further. People can very easily be missed because they're not presenting as classically in women. Whereas actually, the more experience we've got now, the more I'm more attuned to potential things to follow through that I wouldn't have done initially, both my training and my background. To maybe, ask slightly different questions to explore neurodiversity, which I don't think people typically do in services. We have a very prescribed view of what neurodiverse is, and that's often very much embedded within a version of maybe you'd expect more in men. Autism. So I know, as an example, something I've certainly been noticing is the role of like masking in women and how that may be very different to men. We certainly know that a lot of the women we've been assessing are very adept at social situations. They can go into them, which you wouldn't normally expect. Certainly for me, the role of makeup has come up a few times. One of the things I've seen is people quite literally describe their makeup as a mask. They're not just talking about it from a social perspective. They were quite literally using makeup. And I've had people I'm assessing that feel quite uncomfortable, actually. And, as a psychologist, you try and be in tune with what's making them uncomfortable and talk to them about it and try and see what we can do to attenuate that. And it's kind of transcribed as because she hadn't put her makeup on that day because she's got a young child and how she normally has makeup on. And she even described it herself as almost like having a mask. And actually, this is someone that's very able to communicate. I wouldn't necessarily have said has social difficulties, but when you go further down the line, you realize that while she's very adept at them and almost kind of enjoys them, she finds it very draining and then has to sleep and shut off from the world. And I remember, sometimes people need that recovery period, so that they don't necessarily avoid them the same way you might expect in typical autism. But the role of a mask and how women may do those things. They may still put themselves out there. They may still be very good at them and with people, but it doesn't mean it doesn't take a toll on them or have a cost. You're not going to look at. So just looking at how much social interaction someone gets and how presentable they are isn't necessarily indicative of there not being a neurodiverse profile underneath it. But Jenny, I think probably, have you had similar things?
Yeah, definitely. I think just the impact of socializing and how draining and exhausting that can be was something that's really stood out for me. The people describing this and these social hangovers, so to speak, just really sounds like it can have a massive impact on someone's life. And if you're not asking maybe more follow-up questions, you wouldn't necessarily know about that. As you were saying, the kind of classic questions or responses you get, it's fine, or it doesn't suggest there's a difficulty. But then once you ask a few more questions, there's like another layer of challenge, I suppose, which also ties in with another of the things that I've been reflecting on, is how quite often people say that there's always been something not quite right, and people have had loads of different interventions or assessments for different things, and these interventions just aren't getting to the heart of the difficulty or the challenge that people are having, and people are saying how misunderstood and different they felt. And then looking at these difficulties through a neurodiverse lens, you can start to understand why some of these things might be so difficult, or where they might come from, if it is a neurodevelopmental condition, for instance, and that this can persist throughout many years of life, and may just not get picked up in the traditional ways that we've already described.
I mean, something I've certainly noticed as well is what I would call, the reason we approach this from a neurodiverse perspective is something I would call the interaction effect you get with both ADHD and autism. And we tend to view them as being maybe slightly discrete, but actually quite a few people we're seeing seem to have a degree of both. So for instance, maybe something you may look for with more traditional autism is, rigid routines and the systems, and like, all the CD cases in order, or DVDs and particular things. And actually a lot of the people, when they have the duality of ADHD and autism, it may not necessarily look that way, because they don't have particular regulation around their daily schedule. They wouldn't necessarily have, their bookcase all lined up. It can actually look quite chaotic and quite almost like messy, if that makes sense. But then when you dig into their actual environment, they were like, oh yeah, but if anyone moved that, I'd find that really uncomfortable. So there is actually a degree of regularity and routine in there. They like particular tasks which are quite routine based. So even if their lifestyle isn't necessarily rigid, they have very certain domains that will be. And there's always systems in the chaos, I guess, when ADHD meets autism, which you need further exploration. You can't just look at the superficial level you typically look for, and you'd miss a lot of these things. I mean, yeah, I think reflecting on my role in the trial, I'm suddenly finding myself looking back over all my casework over the last 4 years maybe, and suddenly thinking, oh God, actually now think of that person, I looked at that one way, I used X intervention, didn't quite feel like it quite hit the spot, and now I'm thinking, well, if I can put these features together, and I think, well, actually I think I might have been completely missing a certain neurodiverse thing. Even in my personal life, I'm certainly spotting things in, friends and family and stuff that maybe you wouldn't expect necessarily, but you can kind of view with a neurodiverse lens that might be helpful to people, actually. So it's important to think about both our clinical work, but also in the daily world, how people are often wandering around, and you wouldn't necessarily enter the right pathway. Clinicians are all people. We try and be self-aware of our own biases and not let that seep into our work. But I guess we all have some kind of template in our head of a person that has psychosis, or a person that has a learning disability, or a person that has a neurodiverse background. And we need to be very mindful to kind of keep updating those of what we gather in our working lives, to kind of update them, and not only not just be drawn as a clinician to the things we expect in advance, but to keep, updating that. I don't know if any like to add to that.
Yeah, I agree, really. I think before this was coming, or neurodiversity was talked about as much in ADAPT, I was quite apprehensive at almost talking about it with people, and that might not be something they were expecting to talk about for coming into the study about hypermobility and anxiety. But actually, people have often found, or said they found the conversations about it quite insightful and helpful in their whole understanding of themselves. And whilst they haven't pursued a diagnosis, and we're not giving a diagnosis, we're just giving kind of our impression as to, and suggestion that something would require further assessment or further investigation in relation to neurodiversity. But actually those conversations have been really insightful for me as well. And they're not always what you expect. And I'm also just thinking about these conditions much more in all aspects of life, really.
I'm mindful of time, so I just wanted to maybe end with one small reflection from my own, what I've learned from the trial. And I know as a clinician, there can be a certain apprehension to label someone with something which we know is a relatively stable part of them, whereas if someone has a very specific anxiety, I know I can quite simply approach that and give them quite useful strategies, generally speaking, quite well. Whereas to label someone with a neurodiverse profile, there's something very much more longer term feeling about that. And I've been quite apprehensive to have those conversations with people, but actually most people I speak to are almost like, oh, well, as Jenny was saying, oh, there's always been a bit of something. And, oh, well, I remember I had that one friend who was autistic and I really got on with them. And suddenly a lot of things are clicking for them. And actually, you know, maybe as clinicians, we need to be less apprehensive to have these conversations and to offer these labels. And the vast majority of people have been extraordinarily feel validated by the fact we're going, well, actually, this might be a thing. You know, we could help support you to maybe get further assessment adaptations, rather than it being some kind of burden, or people feel they're infringed by receiving these possible suggestions we make and further referral.
Yeah.
I'm aware we're kind of just about running over our slot. As far as I'm aware, I believe Christina's facilitating some kind of Q&A where people will be able to send us emails if they have any further thoughts or questions. We can maybe help to clarify. I would add, I don't claim to be an expert in neurodiversity. I'm just a clinician that works with it, but I am happy to, if I can, offer any answers or comments if you want to get in touch. I'm sure Jenny is happy. I don't know exactly how that's going to work, but I believe Christina's looking into making this facilitate. Other than that, thank you for your time and thank you for your attention. It's been a pleasure speaking today.
Yeah, thank you very much for listening. Yeah, I'm more than happy to receive comments, reflections, ideas. Willing to learn more about this every day, as we already are.
Come and work with neurodiversity. It's great.
Thanks.
Bye.
Bye.